And my name is Liz Woodruff. I'm the Executive Director of the Idaho Academy of Family Physicians, and I'm very pleased to see you here tonight for the second in our Summer Fall Evening CME virtual series at the IAFP, the Gun Violence Epidemic, What the Family Physician Needs to Know About This Public Health Crisis with Dr. Batish. I want to cover just a few quick logistics. Please make sure you are on mute when not speaking. This will reduce background noise during the presentation. You are invited to use closed captioning if that is helpful to you, and you will find that in your Zoom toolbar. Maybe it's under More. If you need closed captioning, you can select that. You may ask questions via the chat box during and after the presentation. You can also unmute yourself when prompted after the conclusion of the presentation and ask your question directly. This webinar is scheduled for 1 hour and we will hope to end on time. However, if your question isn't answered, I'm happy to take your question over email and follow up with answers after the webinar. At the webinar's conclusion, I'll be sharing a link to a quick survey to evaluate the webinar. I'll also send this to you via email with your CME certificate. Please do take a few minutes to provide your feedback. You will receive a CME certificate for this webinar over email within the next month, and then it will be self-reporting to the IAFP for 1 CME. We do hope you'll join us for our upcoming educational content. The next in our series is in September, on September 21st, Alzheimer's and Primary Care, and we are offering a KSA virtually on care of women on October 7th. You can find that information on the events calendar and events page of the IAFP website, and I will also drop it into the chat at the conclusion of today's webinar. So I'd like to introduce our speaker. Dr. Batish has been practicing in Leland, North Carolina since 1998. He is a member of the North Carolina Academy of Family Physicians, the American Academy of Family Physicians, and the Brunswick County Medical Society. He enjoys serving as teaching faculty of medical students. He practices within a full spectrum of family medicine, but particularly enjoys pediatrics, chronic care management, and dermatology. And with that, I'm going to hand it over to Dr. Batish.
Thanks so much, Liz. Honored to be here, and welcome to all of our audience. Again, Sanjay Batish, as Liz had mentioned, I'm a family physician. Have been working in a small independent practice for about 25 years. Have myself and 1 physician assistant, and I've ventured into the gun violence research realm in the last 5 or 6 years, and I'm happy to share what I've learned, specifically as it pertains to family physicians. Okay, let's see. All right. There's a little bit of a delay. Okay, so what we'll talk about is we'll talk about the data connected to gun violence and a lot of information connected to the epidemic, but the take-home message will really be how you can make an impact on your patients and on your community. The data is really clear, and I'll share the data with you, and then we'll come out with a plan of what you can do in your practice to help have an impact on your patients, even starting tomorrow. So objectives, hope that at the end of this discussion, you have an understanding of trends of firearm purchases, have a good or better understanding of the demographic distribution of gun violence, because there is a very interesting distribution. Also have a greater grasp on the financial impact of gun violence on our society, as well as the healthcare system. And lastly, and perhaps most importantly, gain some tools that you can use in your practice to have a positive impact on the rates of gun violence on the patients that you take care of on a day-to-day basis. So we'll talk about trends that are occurring in America, and then talk about data that's more specific to Idaho. There's going to be a lot of data, and I will focus in on we'll really talk about 1 study specifically, but going back a little bit, a little bit about how I became involved in this topic. as probably many of you have patients who have had the lifelong consequences of gun violence, have individuals who have suffer from paraplegia because of gunshot wounds. I have patients who have suffer from PTSD because of witnessing gun violence trauma or witnessing loved ones who've committed suicide because of guns. And I wanted to have an impact and decided to enter the realm of research because I came to the understanding that there really isn't much research. I looked in the AFP journals, I looked in JAMA, I looked in other periodicals, and especially 5 or 6 years ago, there were really no articles to be found. They are showing up now, but I wanted to have some impact on the lack of research that there is in this such an important topic. So what we oftentimes hear about in regarding gun violence are the mass shootings. Unfortunately, there was a mass shooting on Father's Day in Idaho. And that's really what our eyes and ears are drawn to. That's what the public is typically drawn to as well. However, the actual data connected to gun violence is very different than what we see and what we perceive. The vast majority of deaths due to gun violence are actually due to suicide. So in 2021, the total number of deaths accounted for about 48,000 individuals. Just trying to change something on my screen because something is blocking part of the slides. Okay, there. Okay, so 2021 data showed that unfortunately there were 48,830 individuals who died in America. We don't yet have the total tally for 2022. Unfortunately, the expectation is that the number will grow. 48,000 was a unfortunate record for the United States, and we're anticipating that will have a larger number in 2022. The reason we're expecting a larger number is because the rate of gun purchases is continuing to increase. The COVID epidemic caused a really sharp shift and increase in the rate of guns being purchased. And research has shown that the larger the proportion of guns that are being purchased, it goes hand in hand with the gun traumas that occur in America. There's an estimation that there's about 350 million guns in America right now. The majority of deaths, again, occur by suicide. About 45–46% occur by homicide. And then again, a small percentage, 1–2%, occur by mass shootings, which is, again, really what media and public attention is typically drawn to. Now, if we think about there's actually a bimodal distribution of gun deaths. Suicides are primarily start occurring at around age 40 or so, 30 to 40, and have a steady increase into age 60, age 70, and primarily occur in white males. Homicides start increasing at a younger age in the late teens, peak in the late 20s, and drop off and are pretty minimal as an overall by age 40, and primarily occur in Black or brown individuals. So it's a bimodal distribution, and depending on which population that you serve, you're really going to have different disease states, essentially, that you're going to be taking care of. So gun-related deaths and gun violence is shifting from the thought that this is a medical issue that needs to be treated once an individual arrives at the trauma bay. Now it's being looked at as a really complex psychosocial disease state. And depending on the patient population that you serve, you're actually going to be seeing a different presentation of this disease. It is not advancing. Let's see.
Will it advance with your keyboard?
That's what I'm trying.
Oh, okay.
And it's not doing it. Let's try. Oh, okay. Now it did. So these really large numbers, 48,000 individuals who died in America in 2021, that's a hard number. It's a hard number for me to really wrap my head around. And so sometimes putting it in perspective with other death tolls can help us understand the significance of the number of individuals who die in America every year. So compared to the Vietnam War, the deadliest year of the Vietnam Wars was in 1968. 17,000 individuals died that year in the Vietnam War. The flu kills about 22 to 25,000 individuals in America every year. Those are adults. And car accidents comprise about 37,000 cause about 37,000 individual deaths every year. And again, by comparison, gun violence in 2021 took 48,000, more than 48,000 Americans. Now, if we look specifically at pediatric gun deaths in 2021, it was 4,300 individuals. If we compare that to flu deaths, it was only 188 flu deaths in 2021. So again, a really large discrepancy. Something's going on with the advancing. Yeah, it's okay. So looking at it a different way, so I was presenting it, what happens, how many people have died in an entire year. If we look at how many people die every day, 320 individuals are shot every day. From an adult standpoint, about a third of those individuals die and 2/3 survive. From a pediatric standpoint, 22 children are shot every day in America. A fourth of those unfortunately die and 3/4 do survive. And it's really the individuals who survive that we as family physicians are caring for. These are the individuals that we see and care for sometimes for the rest of their lives. This is has a lot of data in it, and what this demonstrates and shows is that America has unfortunately broke a record, and I think a lot of you probably know this already, that America is the leading cause of pediatric deaths in America is now firearms. That happened about a year ago. This slide's interesting in that it compares America to other developed economies, and it shows that for really all other developed economies, the #1 cause of death is typically either motor vehicle accidents or malignancies. And it also shows that the rate of firearm deaths among children and teens in the United States is over 9.5 times higher than in Canada, which is the country that is second highest rate.
Whatever it takes to make you feel good.
Oops.
Yeah, and maybe that's just continuing what you're doing, you know.
Okay, so now we'll talk about the financial burden of gun violence. So Song and his colleagues did a really interesting study that showed the financial impact of gun violence. What this graph shows is the red dotted line are the individuals who have not experienced a gun violence event, and the blue dotted line shows an individual who's experienced gun violence and has had a non-fatal injury. And not surprisingly, immediately after the event, there's a really significant increase in cost, averaging about $25,000 immediately after the injury occurs. The same group looked at other clinical manifestations of gun violence and costs associated with that. And what was found is that there was increased evidence of, not surprisingly, pain, and clinical diagnoses related to pain connected to gun violence lasted for up to 6 months after a gunshot occurred. There was also evidence of psychiatric diagnoses that occurred and were diagnosed immediately after a gun violence event, which lasted about 4 months after an event. And use of opiates and other potential substances of abuse also actually increased, but fortunately decreased within about 2 months post gunshot event. The same group actually looked at the effect of gun violence on the family member of victims. And what was found is that for the 6 months after a family member is a victim of a gunshot, the parents or other individuals have an increased rate of psychiatric diagnoses, and that persists for about 6 months and then comes back to baseline. There was about an 18 to 20% increase in psychiatric diagnoses and manifestations for those family members. And then there was an evaluation of the overall cost of treatment. And this can be really looked at in 2 different blocks. So if we look at individuals who had a gunshot and the level of the gunshot caused the person to be treated in the emergency room and not admitted to the hospital, what was found is that before a gunshot injury, of course, the cost was fairly minimal. During the emergency room treatment, the cost typically is about $7,000 if a gunshot injury is to the level that it can be treated and then discharged from the emergency room. What was surprising is that 6 months after a person is discharged from the emergency room, there's still an exceptional cost of almost $20,000 for the 6 months after a gunshot injury. Now, when individuals are assessed who have a gunshot that leads to a hospital admission, what's found is, of course, prior to the gunshot injury, not much healthcare cost. The hospitalization typically costs on average $70,000. And then the 6 months after a gunshot injury occurs, there's typically a cost of almost $90,000. So when we look at the care on an annual basis of caring for gun violence victim survivors, the numbers are really mind-boggling. It costs about $2.5 billion to care for gun violence survivors. If we take into account other factors that happen when a gun violence injury occurs, missed work, potential disability, other medication costs, the cost jumps to almost $550 billion, which is 2.6% of GDP. These numbers are actually larger than the cost of taking care of non-fatal myocardial infarctions. It's along the lines of the cost of taking care of all comorbidities associated with obesity. So the numbers are really quite striking. So let's talk about Idaho and some of the data specific to Idaho. So this is a busy slide, a lot of information. What this shows is the age-adjusted homicides and suicide rates by state, and this data is from 2018. So this is a scatter plot of all 50 states, and you can see Idaho here in the bottom right corner. The vertical line in the middle represents the median firearm suicide rate for all 50 states, and the dashed horizontal line represents the median firearm homicide rate. And what you see is Idaho is in the bottom right. And what that represents is that Idaho, relative to most of the other states, has a higher than average suicide rate, but a lower than average homicide rate. In comparison, North Carolina is here in this cluster of states, and North Carolina has a slightly higher than average homicide rate relative to other states in the union, and slightly lower suicide rate. What's also important to notice in this graph is some of the other clusterings of states. There's a cluster over here of states: New Jersey, New York, Massachusetts, Massachusetts, Connecticut, Rhode Island, and I think this is Hawaii. And California is in the general vicinity of these states as well. And so these states have the lowest, on average, homicide and suicide rate. And the thought is the reason that these states are clustered and have the lowest essential disease presence of gun violence is because these states have the most robust legislation that has control over guns and has the most legislation and the most laws that assess gun ownership and gun ownership. However, if you look over here, you have Wyoming, Montana, and Idaho. And these states do have some of the least restrictions on gun ownership. Here, you'll notice Mississippi and Louisiana and Alabama. And these states have higher than average homicide rates. And as you may recall, these states have higher, disproportionately higher African-American population. And so it fits from a bimodal distribution that these states would have a higher homicide rate. And these states here have a typically lower proportion of African-American individuals living in the state. And so it fits that they would have a higher suicide rate. So in 2021, there were 309 deaths due to firearms, and the vast majority were from suicide, 80 to 87%. About 9% were homicide and 4% were other, which would be mass shootings. This, as you may recall, is very different than the national presentation. So nationally, about 52% of deaths from guns are suicide, and about 45% are homicide, and about 1% are mass shootings. So this just, again, shows how the disease presence of gun violence differs depending on the population. Looking at the numbers a little bit differently to, again, understand the gravity and the impact that gun violence has. If we compare the number of individuals who died of gun violence from 2002 to 2011 in Idaho, that number is 1,827. If we compare that to the number of deaths in the entire Afghanistan war, that was 1,832. So Idaho has a really significant amount of gun violence relative to its population. So I had stated earlier that the legislation connected to gun ownership has a significant impact on gun violence, and it has an impact on suicide as well. There is an interesting study done by FAAFP that looked at two states, Connecticut and Missouri, and evaluated both these states coincidentally did something to their permit to purchase, requiring a permit to purchase a firearm. During the same year, Connecticut enacted a law that required a permit to purchase, and Missouri repealed that law. And what was found the subsequent 2 years was that Connecticut had a 15% decrease in suicide rate due to firearms, and Missouri had a 16% increase in firearm rate, deaths due to suicide. So Idaho, unfortunately, ranks number 48 in gun law strength, meaning some of the weakest regulations. There's really only 4 gun policies in place, and essentially they restrict guns to not be carried in schools, and guns are not allowed to be owned by someone who's been convicted of a hate crime, but really minimal restrictions otherwise. And I understand that there have been some more proposals to even remove some of these very minimal restrictions. If that happens, the anticipation is that there will be an increase in gun violence, has been shown repeatedly by the data. There's an interesting study that looked at the distribution of suicides relative to geography. And what was found was that there were a few clusters of suicides. One was in the Northeast and the other was in the Southeast. And what these regions had in common were that they were more likely to have population that were Native American, population that were never married. There were individuals more likely to be persons who have are in a state of poverty. Higher proportion of female relative to the other regions, and a greater population of people who have an education beyond high school for those particular clusters. There were some other clusters of note as well. And another study looked at gun violence in Idaho, not from a clustering standpoint, but just from which counties have the highest and lowest rates of gun violence. It was found that Benoit had the highest rate of gun violence, followed by Clearwater and Shoshone counties. The lowest rates were in Madison, Ada, and Latah counties. So what can we do? What can we do to have an impact? Clearly, there's an impact on in America in general, and significant impact on suicide, specifically in Idaho. So what can we do to have an impact on our patients and our community? So first, before we talk about this specifically, let's talk about cigarettes. There was a time when cigarettes were considered to help people with asthma. It was encouraged for people who were athletes to smoke to help them in their athletic prowess. It was Philip Morris advertised cigarettes as very gentle. There were advertisements that more doctors smoke Camels, and it was such a safe product that physicians smoke. Another advertisement saying more doctors smoke Camels than any other cigarette. So it was perceived by a lot of people as a very healthy product to purchase and to consume. And it took a long time. So what this shows is the very slow and gradual arc of rates of lung and bronchial malignancies due to cigarettes, and how long it took for that to gradually change. So it wasn't really until early 1990s that trajectory changed. And the reason why it changed is the idea of cigarette use and the ramifications were understood because of research, as well as looking at tobacco use as a complex disease state. And once that was done, there was a general shift from society, and there was a change in rates of cigarette use, and then a corresponding decrease in the medical outcomes due to cigarettes. The problem from a gun violence standpoint is that there is very little research that's happening right now that's investigating gun violence. Part of that is by design. There was a Dickey Amendment that was passed in 1996 that essentially eliminated all federal funding that would investigate gun violence or firearm injuries. So because of that, there's very little research that's happening. Right now, there has been some funding that has been approved, about $250 million to support gun violence research. The estimation is relative to the amount of morbidity and mortality that guns cause in America, That's about a 2 to 5% of what is actually needed to adequately research such a significant epidemic. But there is robust research that is happening now. Much of it is privately funded, and the hope is that there will continue to be greater funding that will support it. But where we are right now, if this was a curve that represented the gun violence epidemic, unfortunately, I think we're still here. I think we are the next few years, we will likely, unfortunately, continue to climb. That's because the rate of gun purchases, it continues to increase, and the legislation around guns is decreasing in many of the states. So the current perception right now is that guns are a protective tool that they can help in increase in individual safety. There's a thought that having a gun in a home will protect the home, but that belief has been found to be very false. There was a great study, a landmark study that was done by Stuttert that was just published last year. And we'll spend a couple minutes talking about this study. It was homicide deaths among adult cohabitants of handgun owners in California. What he and his group did was they took all Californians, which started off at about 28 million individuals, and they filtered it down to the 17 million individuals who did not have a gun at the beginning of 2004 and followed them for 12 years. What they did is they waited for those 17 million people and watched to see if any of those individuals had acquired a gun in the following 12 years. And what they found was that firearms offer absolutely no protective effect. In fact, what firearms do is they increase the likelihood of homicide for individuals who are in the home. The relative risk is increased for middle-aged and older white men by 5 times compared to homes that do not have a gun. African-American men have a relative risk of 20 times compared to homes that do not have a gun. Households with children have an increased risk of death as well. They also found that the risk of suicide increases for the individual who has a gun. For men, the risk of suicide, if they're in a home that has a gun, increased by 8 times, and the relative risk for females jumped by 35 times. Specifically, the risk of suicide really jumped right after a gun was purchased, but suicides do definitely occur when a person's had a gun for an extended period of time as well. So what I have started to do is I ask every patient about their firearm exposure. And the way I do it in my practice, and what I would recommend, is that we have a dialogue with patients and ask them about gun ownership. In my practice, what I do is ask patients when they are establishing as patients, and then ask established patients when they're coming up for their annual physical. I incorporate it within the same question set as when I inquire about alcohol use, tobacco use, and then I ask about firearm use, firearm exposure, or firearm ownership. It's clear from the standpoint of the large physician professional societies, AAFP, American Academy of Pediatrics, American Psychiatric Association, all of the major associations want us to talk to our patients about guns and gun ownership. Really, this is not going to change unless we get involved and have an active participation on this topic. We need to normalize this conversation within a clinical setting. But how do we do this? How do we ask? So it's important when we're having a dialogue to acknowledge what the cultural norms are for that patient and where the patient is coming from. And we do this as family physicians. This is how we interact with patients. This conversation can be uncomfortable initially. I would say that it's similar to when we were first learning to ask about alcohol use patterns, or even taking a sexual history. These are complicated conversations, but we have complicated conversations every day in family medicine. And this needs to be another challenging conversation, but an important conversation we need to have. When possible, the ideal time to have a conversation about something complicated like this is in an established clinician-patient relationship. And ideally, you don't really want to just ask about patterns of gun ownership and patterns of gun storage. You really want to educate as well, just like we would if we're asking about cigarette use or alcohol use. So some ways of asking: are any firearms kept in around the house? And definitely, if the answer is yes, you want to follow it up. You want to communicate about how the firearm is being stored, if the firearm belongs to the patient or somebody living in the home, and again, how is the firearm stored? So counseling on safely storing the firearms has been shown to be effective and can save lives. So the idea is that if we can increase the time between a person's thought about suicide and access to a firearm, the lives will be saved, and it's been shown to be effective. Suicides have been shown to, this thought of suicide has been shown to be really an impulsive act and driven by a transient life crisis. So this is a picture of a stove, and you may be wondering why there's a picture of a stove in a talk like this. But this is an antique stove in England, and one of the things that happened in England is in the 1930s, 1940s, 1950s, stoves were powered by coal gas, and coal gas is primarily has a really high amount of carbon monoxide, has 10 to 20% carbon monoxide. And in the United Kingdom at that time, there were suicide by using coal gas. Inhaling the smoke from coal gas was the leading cause of suicide. In the 1950s, they started to change how they supplied fuel to these ovens and stoves. They changed it over to natural gas, which has a very low amount of carbon monoxide. And by 1970, the rate of suicide, the overall rate of suicide, had dropped precipitously and had not been replaced by other forms of committing suicide. This example has been shown by changing catalytic converters in automobiles, which again reduces the carbon monoxide, so the rate of suicide using that modality has decreased, or even using creating protective methods around bridges and railways has been shown to decrease suicide. Because again, if that modality is taken away, it's been shown not to be replaced by another modality. So there's a great class I would recommend that you take. It's only a 1-hour class. It's called Counseling on Access to Lethal Means, short for COM. It's produced by the Harvard Injury Prevention Program. And what it's specifically about how to talk to your patients when they may be in a crisis, or if they are showing signs of going into a crisis. Some of the highlights from the COM class would be, if a patient is having a history of depression or showing signs of distress, it's really important to ask a direct question. An example would be, tell me about a couple of times in the past few months when things were at their worst. Did you think of suicide? So a really direct, specific question is very important. when a person is considering suicide, again, creating some distance between a person's firearms and the individual is of critical importance. So this is a map of North Carolina, and we, a group of individuals looked at police stations, sheriff's departments, and gun retailers that were willing and interested in temporarily holding an individual's firearm if they were in a mental health crisis. And these locations are scattered around North Carolina and quite available. We called a few, we called actually some of the sheriff's departments and police departments in the areas that had the highest clusters, in that northeastern Idaho and the southeastern Idaho. And unfortunately, the police departments did not express a great deal of interest in this concept. They didn't have really any information or knowledge about the safety storage concept. I would encourage you to contact your police department, communicate that this is a very common practice done in much of the country and would be of benefit to your community. So medications are actually the most common method of suicide attempt because of their accessibility. So, why are firearms the #1 cause of suicides? The reason is that they're the most lethal method. They're almost always irreversible if a firearm is used. They are extremely accessible. Idaho has about 70 to 75% gun ownership. And is in suicide with firearm is acceptable in many communities. So this demonstrates the lethality of a suicide attempt with a firearm. So if we look at all suicide attempts, only 5% of suicide attempts are with a firearm. 95% are by other means. Most of those other means are generally with with medication. But in this 5%, 90% of those attempts result in death, with only 10% resulting in a survival. So this conversation, when a person is looking like they're in a crisis, the idea of encouraging the patient to separate themselves from the firearm in the home, it's key to have that conversation be a collaborative conversation. You want the patient to really be the expert because they know about their firearm or firearms. They know what their belief system is, and you want to be the resource that can help guide where this firearm can be stored. If your police department or retailer, gun retailer in your community is not a good resource to hold a gun, it may need to be a relative, or if nothing else, placing a lock on the gun would be a great benefit. You want to emphasize that this is temporary in nature, that it's not a permanent removal of a firearm. And the goal, you want it to create a feasible and really specific plan. So this is a short video about gun locks. It's important for us to be informed about the two main types of gun locks.
Dr. Batish, I'm not getting sound on this. I don't know if others are.
Okay, we will, I'm not sure how to fix the sound, but it'll be in the slide deck. And so I'll move on from that. But what that video does demonstrate is the use of a gun lock, this type of gun lock, as well as the trigger lock. But I was not knowledgeable about how the gun locks work. I did look to see if any of the Idaho police departments had a video but they did not have a video. So this is a police department from California. Some other resources that are available to you and additional resources. The last one is the COM, which I would highly recommend. The course takes about 50 minutes or so. Okay, and one additional resource, this is called Bullet Points. This is out of UC Davis, and this is an excellent program that's also designed for clinicians and tools that clinicians can acquire to help gain more information about how to counsel patients regarding gun safety. Okay, thank you.
Thank you, Dr. Batish. That was a really excellent presentation, super comprehensive. Really appreciate the time you took to look specifically at Idaho. That I think will be really meaningful to our attendees tonight. So I invite people to put any questions you have in the chat and or unmute. We do have a question and a remark in the chat. I'll start with the first question from Dr. Bennett. Where do accidental gunshot wounds fit into this?
So the idea is that fatal wounds comprise for adults about a third of the injuries. Most of the non-fatal wounds are felt to be accidental. And so the main place that accidental wounds would fit, or the main advice I would have regarding accidental wounds or preventing accidental wounds, is the idea of the gun lock. So it's been clearly shown that when gun locks are implemented, the rate of accidental injuries is greatly diminished.
Thank you. And then there's a remark in the chat, and I think what the Dr. Conger is addressing is there an issue even in states where there may be laws regarding firearms with the enforcement of those laws? So, you know, and I don't know how that may play out in the data
Sure.
that you shared, but if you could address that.
Sure. So I'm not sure how to specifically answer the enforcement part of it. But what has been really clearly shown is that the greater the number of regulations around gun ownership, the lower the rates of injury, death, and suicide. And the thought is that that when there are layers, increasing layers of placed upon gun ownership, there's greater sense of responsibility with the gun owner, and that's why there are decreased injuries and decreased fatalities.
Thank you. And Dr. Dunn asks, is there any likelihood of federal legislation on gun control passing anytime soon?
No. Tragically, I think what is going to happen is that there's going to be increased research. So really in the last 3 or 4 or 5 years, the rate of research on gun violence has increased. So the amount of research is going to increase. And what that is hopefully going to do is it's going to slowly create a shift in the conversation and also what the media talks about, because right now they really are still focused on that 1 to 2% of gun deaths, the mass shootings, and the second thing that they're focused on are the homicides. But really, in much of America, the biggest problem is suicides. So my hope is that with more research, there'll be the change in the conversation about the problem in the disease that this disease is causing. And we will look at this more and more as a public health crisis and take it out of politics and look at it as a disease state. We were able to do this with tobacco. It was surprisingly political way back. Even with HIV, it was a political issue. And when we brought it more into the healthcare lens and the public health lens, we were able to we were able to have great success with it. So I think it's going to come from sort of the ground up, and it'll hopefully happen more in the States. There's a very interesting law that I think San Jose has passed, which now states that if a gun injury occurs, the person who is the gun owner is then responsible for the damage that is caused. Essentially similar to a car. So if you own a car, you cause damage, you're responsible for it. And it's an analogous law for guns. And so there's research that's looking into what are the ramifications. So even though there are states that are reducing regulations, there are states that are implementing creative regulations that shifts the burden of responsibility to the gun owner.
And I would invite any other questions, either in the chat or if people would like to unmute to ask Dr. Batish directly. We'll take a second to see if we have any more questions or inquiries.
I would definitely be interested in anybody's feedback. So this is my intention is, one of the reasons I wanted to get into this space is to be able to communicate what we can do as family physicians regarding this important issue. So if you have feedback, and you can send it to Liz about how I could I could adjust the message. I would welcome that.
And I, in the chat, have provided a link to a short survey to provide feedback on the presentation, both in terms of learning objectives, but there's an opportunity you can have there to give other kinds of feedback specific to what Dr. Batish just asked. We're really grateful to him we're grateful that we are part of the development of his communication with family physicians in this way. It's great to be able to collaborate. And so your feedback's important. I also dropped in the chat the flyer for our upcoming virtual CME, including Dr. Batish's is still on that flyer, so you can note that there, but we'd love to see you on September 21 or October 7th for our KSA on care of women. Dr. Devitt added in the chat that she thanks you for this research and information, Dr. Batish. And then I'm going to drop in the chat a link to our the IAFP's suicide prevention project. We actually, and I should have said this earlier, connected with Dr. Batish through IAFP and the Ardmore Institute. The Idaho Academy of Family Physicians received funding to do a lifestyle medicine project that addressed the lifestyle medicine pillar of social isolation. And we are actually in 3 rural communities, family practices in the state right now, implementing a suicide prevention screening and referral project. And so with the link that I put in the chat to that page at the bottom, you can find our physician and our patient resource packets. And I'm really happy to say that as part of this effort, we were able to deliver gun safety locks into all 3 of those practices. And our doctors in those areas are distributing them now. And while I don't have the capacity to do large scale distribution, if you are interested in receiving a set of gun safety locks, I can help make that happen. And many of you have my address, but I'm going to drop that in the chat too. We're actually also working on getting medication lock boxes distributed as part of the project too. So I'm starting to explore those avenues, and we can be resources on those things. So we're really grateful to the AFP and the Ardmore Institute. We were connected with Dr. Batish, and we thought as part of that specific pilot and effort we're doing with just 3 of our physician practices, this was a great opportunity to bring the larger gun safety issue to all of you. Any other comments or questions from the group for Dr. Batish?
I would also say that if you do run out of the locks, Liz, there is a project Child Safe that really the local law enforcement has access to these free locks, and in much of the country, the law enforcement gets the locks from Project Child Safe and distributes them for free to the community. So that would be another resource to connect with your law enforcement and ask them about Project Child Safe.
Wonderful. Thank you so much. And I should also say CME certificates will be delivered to folks within the next month, and we will have Dr. Batish's recorded presentation up on the website. We're in the process of curating a page of our CME, virtual CME content, so you'll be able to find that there. I expect us to also feature it specifically on our suicide prevention page. And you will receive a PDF of this presentation with your CME certificate. Dr. Batish, if you don't mind, I don't think I've asked you yet to send me the PDF so I can share that so they have access to the slides and resources. And Dr. Batish, is there anything else that you want to add before we close?
Thanks so much for the opportunity.
Well, it was an absolute pleasure to have you. We really appreciate everybody's time and interest in this very important topic. Look for the resources in your CME certificate soon. Let me know if you didn't have any questions that were answered. Dr. Allen, Dr. Batish just said thank you. Another thank you from Dr. Davis to you, Dr. Batish. So I know that our members were very grateful, and we'll look forward to making sure that even more. And Dr. Bennett said thank you for your time and efforts. So lots of appreciation, and we'll make sure to amplify the communication that you had here tonight with the rest of our members. And I hope everybody has a very nice evening.